All right. Kenzie. And I think we're just missing one, so that's not bad. Hope everybody's doing well. Had a good weekend. We are going to talk about a couple different things today. Um, we've got content on soft tissue injury and just trying to kind of tie together the different types of exercise that we do with patients and when each type is kind of appropriate. We did that a little bit when we went over range of motion, talking about when we would do passive, when we would do active assisted, when we would do active. Um, so we'll talk a little bit about that, and then kind of when you introduce the different types of strength exercises, the different types of stretches, things like that. But I think I'm going to go ahead and start with the other content, which is more about osteokinematics, arthrokinematics, and how that applies to doing peripheral joint mobilizations and mobilizations with movement. That's what we're doing in lab this week. I want to make sure that I get through all of that content really well so that people understand it heading into lab this week. And then I think we should have time to then go through the soft tissue injury stuff. So let me go ahead and scroll forward here a little bit. And most of this should be reviewed from Kines, at least the basic principles. What will be new is kind of talking about how we specifically decide which way we want to move a given joint to help improve its specific motion that's lacking, whether we want to improve somebody's flexion, whether we want to improve somebody's abduction. It kind of depends on which bone we're trying to mobilize relative to the other one. So let me keep cruising here. I had to bring my skeleton friend over because I'll probably borrow him. And I thought about laying him down on my plinth, but I was worried that he might tear the plinth. That's not my plinth or my skeleton for that matter. So, all right. So let's look at some definitions to start with. Term mobilization is kind of the more common one that we're going to use in therapy settings. Manipulation is kind of more common in chiropractic realm. That's not to say that you won't hear a chiropractor say that they're doing a mobilization or a PT saying that they're going to do a manipulation. But that they basically mean pretty similar things. We're doing a passive motion in a specific direction at a specific joint to try and improve the overall motion for that patient. We can do mobilizations for different reasons, and we'll kind of go through what people theorize they do and help with. But really what we're talking about is just trying to help the internal arthrokinematics of the joint work a little bit better so that the osteokinematic functional movements of flexion, extension, abduction, adduction, etc., will be easier to perform or less pain-free, or excuse me, more pain-free, decreased pain, improved motion. So that's kind of why we do these techniques. We can teach patients how to do specific self-mobilizations, and that's what you see this woman down at the bottom on the foam roller, kind of trying to mobilize the thoracic spine, and many people do that type of motion themselves. We also have a lot of people that are so-called self-manipulators that are frequently popping their neck, popping their back, popping their knuckles. And when you're doing that, you're essentially doing a mobilization. Now, whether it's skilled and really the way that you want to move that joint's another story. A lot of times when people have a tendency to kind of pop all their different joints all the time, especially if you look at the spine where we've got so many joints in a row, you'll tend to have the easiest joint, the most loose joint pop first. And so when you pop your back, it's often that same segment between, let's say, T5 and T6 that's always the one to go. And every time you do that, you're kind of overstretching that joint capsule and making that joint potentially that much more unstable. So when we choose to do a mobilization on a patient, we don't want to just do a general mobilization just because it feels good. We want to understand which particular motions are restricted at which particular, say, vertebral segment is getting stuck. And that's what we're going to try and help. So it's generally not a good idea to do a bunch of your own mobilizations that are non-specific. If you have a given technique that specifically targets the segment that you have in your back, for instance, that does tend to get stuck, that does tend to not move the way that we want it to, then that's one thing. But to just randomly just try and see if you can pop everything that you can is probably not the best idea in many cases. You're going to cause some increased instability in the joint. And that's especially true for people that already have really mobile joints that have extreme ranges of motion. They're the ones that really need to be that much more careful about doing excess self manipulations. So we are mostly trying to, when we do these mobilizations, try and improve the movement of the joint capsule. If it's tight on one side of the joint or the other, then we're trying to kind of lengthen it a little bit specifically. But the other part is that we're mostly trying to help facilitate and improve glide between the bony surfaces, improve roll, improve spin, whichever of the accessory motions might not be working very well at that particular joint. And it would depend on what joint type it is. So kind of depends. We'll go through those things. So we've got some more terms here. And so let's look at the middle two just for review, because you've probably heard those terms already. So physiological motion is what we measure with the goniometer, whether it's abduction, adduction, internal, external rotation, flexion, extension, that's those type of motions. What are basically the osteokinematic motions? How far are the bones moving relative to one another? The accessory motions are what we're really after in trying to improve when we're doing joint mobilizations. We're trying to help them usually glide better. The roll and the spin are less common things that we're going to try to facilitate. Mostly we're trying to get the glide to work out a little bit better. And if the glide works better, then the roll and the spin will also work better if the joint is capable of doing those type of movements. So hopefully those terms are just a review for you. Now, at the end of this set of content and with our second lab this week, we'll be going through mobilizations with movement. And a mobilization with movement is a little different than just a passive mobilization that we might do on a patient. With a mobilization of movement, we're essentially applying a sustained force to the joint while the patient actively tries to go through the given motion that we're trying to improve. So it's a little different than just having the patient passively lie there while we move one bone relative to the other. So it's a much more active thing. And we can use our own hands to help with that mobilization while they're moving. We can use different belts and straps. We can use sometimes the really long elastic bands can be used to help a patient do those type of things themselves, because that elasticity can provide that kind of sustained force. And we'll talk about a little bit more specifically about that as we go. The bottom term there of muscle energy are ways that we can either help the patient use their own muscular strength to self-mobilize. And usually this is done most commonly with the SI joint and the pelvic bones. We've got a couple different techniques that can be used to help engage muscles to cause pelvic halves to shift relative to one another. And I'll pull over our skeleton here and see if I can show a couple of those briefly. Let me check my camera. And I'll probably dip down just a little bit. This is where I thought about putting my guy on the plinth I have, but I didn't, my skeleton. All right, so you can get your patient in supine like this, okay? One technique that can be used for SI problems is to basically, he's not moving very well, put your hands on the outside of the person's knees and block them from moving, and then you're going to have them do an isometric hip abduction. So they're trying to push their legs apart. You're blocking them and not letting them go anywhere. And what that's going to do is it's going to transmit force through the back of the pelvis where the femurs are going into the pelvis. And essentially by pushing out, you're going to make the pelvic halves kind of push backwards a little bit. So it'll kind of compress the back of the SIs and kind of gap the front of the SIs. Usually you'll do that, and then you'll follow it up by just the opposite. You'll put your arm in between the person's knees and now have them isometrically contract the adductors to kind of pull together. And when they do that, then it's going to tend to gap the back of the SIs and kind of compress more the front of the SIs. And so sometimes that technique, kind of alternating, going back and forth between have the knees together and push out, have the knees apart and squeeze in, can help reset and kind of help those bones shift back into place and get that SI to sink back up where it's supposed to be. The other one that's pretty common with the pelvis is if you have one pelvic half that is rotated up or down relative to the other. And so if we'll usually investigate that by kind of looking at the person from behind, and we'll try and find where those PSIS are. And if one PSIS is higher than the other, then it can be that that side that's higher may have shifted forward, and so that PSIS goes up, or it could be that that side shifted downward, and so now the one that is high is actually the one that's normal, the one that's low is the one that has shifted out of place. And so we can do kind of a similar technique to the last one, except in this case, you're going to put one leg way up into flexion and block it at the hip. The other leg is going to stay neutral. So I'm holding the leg down. Now in this position, I can have the person, depending on which pelvic half has shifted, do a couple isometrics. If this right pelvic half, the one that I'm holding the leg up into flexion, has shifted up, then we want to pull on the ischial tuberosity to pull it back down. And so if I block this leg up like this, and I block the other leg and hold it down, what I'm going to have the patient do is kind of like a scissor type contraction where they're pulling down with this flex tip to engage the hamstring and try and pull down on the back of that right pelvic half. At the same time, I'm blocking the motion on the right leg, and they're trying to flex that hip. And by flexing that hip, it's going to really, and because I'm anchoring it, it's going to stabilize that left half of the pelvis so that more of the force that the patient is exerting is now able to kind of leverage on the pelvic half that's out of place and hopefully pop it back in correctly. Now, if I was shifted the other way and shifted downward, then I would want to switch my positions, and now I would do that just the opposite. I'd have them pull down with the opposite side and pull up with the side that had shifted down. So those are just a couple examples of muscle energy techniques that can be used to help with that SI. Now, I haven't done enough outpatient ortho. I know there's other muscle energy techniques, but those are the ones that I know of that are probably the most common ones that you'll see done a lot. How many people have seen a therapist in your clinic do one or both of those? And so they can be pretty effective in helping to relocate those SI joints and help just really quickly relieve that person's pain.
I've had those done and they work really well, especially if we can have some manual work done or maybe heat to relax the muscles.
Yep.
Or else it's just painful because the tight muscles want to keep everything where it is.
Yeah. We'll talk about kind of the sequence of ideally, if we're going to do a mobilization, what other things we want to go in there with it to help make them be most effective. So that's kind of, I think, the end of our just definition sheets.
Hey, Craig.
Go ahead.
So whenever you're doing those, and something pops, is that good, bad, or just kind of something that could happen? Or is it like, what exactly is a popping? I know what it is, but is it good or bad, basically, is what I'm asking.
I mean, if you have correctly identified like that one pelvic half has shifted up higher than the other, then that pop is usually it popping back into place where it's supposed to be. So that would be a good thing. You know, the most common noise that the pop is from, they believe, is just a kind of a collection of nitrogen bubbles in the synovial fluid itself that we then pop and it kind of disperses. But it can be other things too. And certainly that sometimes it's more of a clunk than a pop. It's not like the pop you get when you crack your knuckles or something like that. It's more of a clunk as that bone shifts into place, because those SI joints aren't like most of our synovial joints. They have those rough surfaces that kind of interlock with one another to hold it stable. We don't really want them moving a whole lot. So it's kind of a different joint than many of the other ones that we'll look at. All right, so looking at helping understand how to mobilize a joint, we need to understand the different joint surfaces and kind of how they fit relative to one another. Now, this term ovoid refers to basically everything that's not a sellar joint or a plane joint when we look at our synovial ones. So a pivot joint, a hinge joint, a ball and socket joint, the condylar joints, those are all considered ovoid. And so when we have an ovoid joint, we have one side of the joint, one bone in that pair that has a convex surface, and the other one has a concave surface. And so that's the example that we see kind of right here. And this could be like one of our IP joints, let's say. This top portion would be the proximal segment. The bottom portion would be the distal segment. The top portion here would be our convex, and the distal segment would be our concave. When we look at a sellar joint, that's what's pictured over here. They're often called a saddle joint because it looks kind of like a saddle. It is convex in one direction, but concave in the other direction. And so if we're trying to improve a certain motion with a sellar joint, we can do a joint mobilization, but we kind of have to know which way are those two surfaces oriented to one another. And I've got a hand here. Let's see if I can hold it up kind of close. I better wear my glasses so I can point at the right thing. And so this is, you're looking at the dorsum of this hand. And so as I hold it up, you can see where the proximal, or where the metacarpal is coming down and hitting the trapezium. From this angle, the trapezium is concave and the metacarpal is convex. If I turn it the other way, it's kind of oriented the opposite way. Now we're convex on the trapezium and we're concave on the metacarpal. So that's our CMC joint. Again, debatable where we have other ones, but the SC joint is considered in many references a sellar joint as well. And so again, if we're trying to mobilize this joint on the thumb, it would depend on whether we're trying to improve its flexion extension ability or its abduction ability, kind of which way we would want to mobilize it, because we do have those, each surface has both a convex and a concave plane to it. So because of the way that they're shaped. So these are kind of the exception to the rule. If we look at something like the vertebrae, now we just have mostly plane joints that we're talking about. And mostly what you're mobilizing usually are going to be between the facet joints themselves. And so we're trying to basically glide those surfaces relative to one another and help improve that gliding motion. And we do have to understand with the spine how the facet orientation changes from the cervical spine to the thoracic spine to the lumbar spine. The angle of how those bones fit together is different in those different segments. And so that can influence how effective we can be with our mobilizations at those joints. So important to kind of understand those. Again, the ovoid is what we'll talk about most often in understanding which direction to perform your glide when you're doing a joint mobilization. Questions? You guys doing okay? So far, so good. All right. So again, what we're looking at are our accessory motions, our roll, slide, glide, translation. Those all basically mean the same thing, just shifting one bone relative to another. And then we have some of our joints that are going to spin. And then compression and distraction are also considered accessory motions. And these are ones that are really easy for us to perform on the patient as a joint mobilization. That can be really good for kind of relaxing and things like that. They don't necessarily help as much with improving the motion, but they can help with improving some of the other things that we believe mobilizations help with pain relief and just helping loosen things up a little bit. But in most cases, when we're doing a specific joint mobilization, we're mostly trying to help it slide or glide better. All right, so just reviewing those motions, our roll is a series of points on one surface coming in contact with a series of points on another surface. And so that's easiest always to see with the femur and the tibia. If I'm sitting down and I go to stand up, my femoral condyles have to roll on top of the tibia. Now, as they're doing that rolling motion, they have to slide backwards or else they're going to come apart. If I just kept rolling, I just roll right up the front. And so as it's rolling anteriorly, the femur, it's got to slide posteriorly to stay in contact with the joint. If we're looking the other way and I'm doing a knee extension exercise and coming up this way, now my tibia is rolling across the surface of the femoral condyles. And it's moving in the same direction that it's rolling. So this is our convex and our concave rule. And that's what you really have to be clear on understanding to figure out which direction we need to mobilize a joint. And we'll come back to that. So just kind of talked about those concepts. Spin's a little different. We don't have as many joints that spin. Really, our pivot joints and our ball and socket joints are going to be the primary ones that actually spin, have that ability. You kind of need that that horizontal plane motion to be able to need to spin. And so the radius where it hits up against the humerus on the capitulum, we have that rounded kind of little ball that's at the end on that capitulum. So that's our convex surface. And then the little kind of dimpled, indented portion on the head of the radius is our concave portion. And so they do just kind of spin in place. If you imagine like a top just spinning and not moving across the floor while it's spinning, that's kind of more what's going on right there. The second little bullet point or second major bullet point says it doesn't occur in isolation during normal joint motions. And I was like, well, it pretty much does when we look at just doing pronation and supination. We can isolate just pronation and supination and that spin can occur. Where it doesn't tend to occur in isolation would be more with like our ball and socket joints. If I'm doing hip flexion and hip extension, then it's going to spin while you're accomplishing those motions. The rounded head is going to be spinning in place on the socket to a degree. So I didn't really agree with that bullet point, so I added that just this morning, except maybe in the pivot joints part. But the way the ball and socket joint spins is a little different than something that's locked in, and where spin is really only motion that we see at the pivot joint very specifically. So a little different with those. All right, so there's our convex and concave. Hopefully that's a review from Kines. When the convex bone is the bone that's moving, the slide's in the opposite direction of the angular motion. And that was the example that I had here. If I'm standing up and my femur is coming up, my femur is moving anteriorly. In order for the joint to stay in contact, it needs to slide posteriorly so it stays on top of the tibia. If the concave is moving, that's the opposite. If I have my tibia moving on my femur, I'm doing my knee extension exercise. Now I've got the concave surface moving in the same direction. My tibia is moving up, and I'm also sliding up as I do that, or gliding up. So the concave is always in the same direction. And that's how I keep them straight, that you've got this A in concave and this A in sane. And that's what works for my brain to help me remember it. Whatever works, as long as you remember it. So if that's helpful, great. So that's really the key thing to understand with most of our peripheral joints. Now the spine, because those are plane joints, it's more about understanding the angle of orientation of those facets to kind of know which way to glide. And we can't really, because of the rib cage and everything else in the spine, we really can only kind of glide front to back. With the spine, we don't really have the ability to glide things side to side very effectively, at least in the thoracic and the lumbar spine. The thoracic in particular. The lumbar, we can do it a little bit. Cervical's easier because you can control the head and kind of move it a little bit more discreetly than trying to move a thoracic vertebrae. So convex and concave, everybody good on that? Okay. All right, compression and distraction. So compression, if it's sustained, is not really considered to be a great thing for the joint. So if you're just like standing in place and not moving at all, and all your body weight is just continuing to push down on all your vertebral segments, on your, your hip, your knee, your ankle, if we don't move at all, then that's not really a good thing for the joint. But cyclical compression is believed to be one way to help circulate synovial fluid. So when we shift our weight side to side and we offload one leg and then reload the other leg, we're essentially compressing one side when we shift the weight to it, and then kind of uncompressing it a little bit or distracting it somewhat when we shift the other way. And so that's good. And that's going to happen with every movement we do, every action we do. It's going to do that. And when we do joint mobilizations for compression and distraction, we're basically just trying to separate the joint surfaces and push them together. Separate them, push them together. Separate them, push them together. Distraction is pulling them apart. Pushing them back together is the compression part. And like I say, we don't usually do a joint mode where we're trying to jam surfaces together. That's not really the healthiest thing for those joints. But if we're just moving them back and forth, because all that synovial fluid's contained in that joint capsule and it's a finite space, as we move those bones relative to each other, it allows that synovial fluid to kind of move around and help bathe the ends of the joint. And that's believed to be beneficial from a health perspective for those joints. All right,
Okay.
so traction versus distraction. Again, yep, Allie.
Sorry, I have a question. So compression and distraction, is that the only reason you would use it is for synovial fluid, like mobilization?
No, you can sometimes do distraction and actually cause a release of the synovial fluid bubbles and kind of get a pop. Sometimes people can just pull on their fingers and pull them apart and they'll get a pop to try and relieve some of that pressure. That is the main thing, but it can also be pain relieving to help the person kind of understand that it's okay to move those joints. It gives you a little bit of proprioceptive feedback. We'll kind of go through this whole laundry list of things in just a minute about what the proposed benefits are, theoretical benefits are for doing these different joint modes. Allie, did you have a question too? No? Oh, I thought I saw a hand. Okay. So,
You did. I was just raising mine so that Amanda could ask her question.
Okay. Well, that was Malia. Wait, does Amanda have a question too?
No, I'm sorry. I didn't know who was talking.
Okay. All right. Thought I was missing something, which is possible because I can't see everybody. I can see everybody. All right. So traction and distraction can be different things, but they can also mean the same things. It depends on how the joints line up with one another. So hopefully you've never been fooled by the pull my finger trick in recent years, but maybe when you're in elementary school, you might have. And so when you pull on your finger, if I'm pulling my distal phalanx away from the proximal phalanxes, I'm doing both traction and distraction. Okay, traction is a pulling apart force in line with the bones themselves longitudinally. A distraction is separating the joint surfaces. So if I pull my, each of my bony finger segments are in line with one another, and if I just pull on one end, I'm going to separate all of those surfaces at the MCP joint to a degree, at the PIP, at the DIP. Now, if I stabilize, if I had another hand and I just stabilized my middle phalanx and just pulled on the distal, then I would just be getting distraction at that one segment. And so we want to, when we're doing treatments like this, we want our efforts to be focused on one specific segment. Typically, we try to not do multi-segmental kind of treatments like that. With the shoulder, we have a little different way that we apply that term traction and distraction. This A picture is just pulling that arm straight down. The B picture is pulling that humeral head away from the fossa on the scapula. So which is A showing, traction or distraction?
Traction.
Traction, okay, and then the B is showing the distraction. And so if we're gonna do shoulder treatments, when we do a joint mobilization technique, we pretty much always want to separate the joint surfaces a little bit before we try and move one of them relative to the other. And so when we do shoulder, we always need to think about, we need to distract the joint first and separate the head from the fossa before we then try to glide the head in one direction or the other, whether we're gliding it front to back, whether we're gliding it up or down, or whichever other plane we're trying to affect the movement in. So important to understand the difference between those terms. For many joints, they're going to be the same thing. If we talk about it for the spine, traction and distraction are the same thing. If we're applying that force vertically to pull the head away from the body or to separate the lumbar spine. If we look at the knee, traction and distraction would be the same thing. The shoulder and the hip are going to be the main joints where they are not quite in line with one another when we look at that, because we do have that ball and socket configuration where the bone comes in kind of from the side to the joint rather than stacked one on top of each other, where the bones are in line with each other. All right, so here's our big list of things that joint mobilizations are supposed to help. So neurophysiologically, we are stimulating mechanoreceptors, our pressure receptors, our tactile receptors in the skin that sense deep pressure, light pressure, all the receptors in the capsule themselves, tendons, things like that are ligaments that have potential mechanoreceptors. We're going to be giving them information. And by giving them information, sometimes that's enough to just confuse the brain to make it feel better when we start moving it. So very similar, you guys talked about gait control theory and modalities. So kind of the same thing. If we have that buzzing, tingling feeling from the e-stim device, it interferes with potentially our pain signals. And so if we can get these mechanoreceptors sending information to the brain, it can sometimes interfere with the person's pain signals and help them now go, oh, you know what? Yeah, it does feel better to move after you did that. We didn't really probably change anything with the tissue, but we basically are tricking the brain into going, yeah, it's okay to move that way. You can get that motion back. So it is also potentially believing to kind of interfere with some of the pain signals. And then it can help give that person, especially if they haven't moved that body part in a while, they're just coming out of a cast, for example, it can help them start to regain some of that sensory feedback that helps us understand how to balance on one foot when we're taking a step, how to react when we lose our weight side to side, things like that, if we're talking about doing these type of moves on the foot or something like that. So it does believe to be helping with both kind of pain relief as well as just improving our inner sense of proprioceptum and that internal feedback that we need. The movement of synovial fluid is kind of this main component in the middle there, those nutritional effects. The ends of our bones have pretty lousy blood supply, and that articular cartilage, in order to stay healthy, we need to move. It's going to help with promoting fluid movement and help those joints get some of their nutrition and get rid of some of the waste that they might be producing in those cells. And then the true mechanical effects are the things that we might actually be doing to those soft tissue structures that would help them improve the motion for that patient. So just getting the joint gliding and moving a little bit more appropriately. If we do have any type of scar tissues from a joint that's been kept immobile for too long, from lack of use or from cast or brace or any of those type of things, and then potentially stretching out some of those tissues too, so that the body part can move a little bit more freely. So that's kind of the idea on why we do joint mobs in general. Yeah.
It's really cool to learn about the e-stim and how it kind of helps the patient, so that when they ask us why we're doing it or how it works, we can kind of explain the gait theory to them.
Yeah. Now, I used to teach modalities, and it always bothered me when I'd hear about PT clinics, and those that have outpatient clinic experience have probably seen therapists do this in many cases. They'll put on e-stim, and then they'll put it on with combination with ice. And if you're numbing the body part, then you can't really feel the e-stim. So you're kind of defeating the purpose of using IFC for pain control if you can't feel it anymore. And if you numb the body part and then they're like, oh, I don't feel it anymore, can you turn it up? Now you have them turn it up, well, they don't have good sensation, and you have a much higher risk of burning the patient potentially with it. So I'm definitely a non-believer in combining e-stim and ice. If you want the effect of ice, just use the ice. But ice isn't really billable where e-stim is. If you want the gait control theory to work, the patient has to feel it. You can't numb them.
I've seen that done, especially after a total knee replacement, where they may still be a little bit inflamed, so they don't want to use heat. So they'll use ice with the e-stim. Do you think that beyond the gait control theory, that it could still be effective in another way, like especially if you don't turn it up to cause injury?
I think if you're doing a high volt, then it might have some different effects, because that tends to have a little bit more of low rate TENS as opposed to a high rate TENS, like an IFC type current. That has some different physiological effects, but you still need to feel it. If you're trying to cause those effects, you need to feel that buzzing feeling, or you need to feel that more strong kind of jolt that we see with low rate TENS. Have you guys tried low rate versus high rate yet? Low rate doesn't feel nearly as good, but it's believed to have longer lasting effects after you take the pads off. Whereas high rate, like IFC, feels good while it's on there, but once you take them off, you pretty much don't have the gait control theory happening anymore. The low rate is believed to cause more of like an endogenous opioid release that gives you kind of a natural internal pain killing effect. But with both of those, you have to feel it. And so when you use it in combination with ice, to me, physiologically, it makes absolutely no sense. You're defeating the purpose of the e-stim by numbing the body part with the ice. If you want to do one followed by the other, then do e-stim followed by the ice. Because if you do ice first, you're not going to feel the e-stim.
Can you clarify something real quick for me?
Uh-huh.
For IFC, can you tell me which one's the high frequency and which one's low? Is 1 to 10 low or high?
That would be your low. Yeah, the high is more like the 150 or something like that.
Okay, so okay.
There,
Good.
yeah. Most of the time when you do IFC, you do high rate,
Okay.
but you can do either IFC or TENS with a low rate. All right. So they're definitely.
Sorry.
Go ahead.
I'm so sorry. I have a question with the ICE and IFC.
Yep.
So at my clinic, we had somebody come in that had just sprained their ankle. And so it was swollen, starting to bruise. And the PT wanted to do ICE and IFC. Is it kind of similar to what you've been saying of just do ICE and then do IFC? Or?
I mean, if you've got a lot of swelling, then you'd be better off doing something besides IFC for e-stim. You'd be better off doing like HVPC, where you actually use a polar instead of having a bipolar. You use a unipolar current, and that's believed to be better for edema reduction. But if you're strictly trying to do pain control, to me, again, if you numb the skin so you can't feel the e-stim, then you're not getting any gait control effect from the e-stim. But it's very common clinical practice to see that, and it, to me, like I say, it just doesn't make any sense at all to do it that way, because you have to feel the e-stim in those cases for it to help relieve pain.
Yeah. Okay. Thank you.
Yep. All right. So we don't want to do mobilizations when people are already super mobile. Kind of like if you have really great muscle length, you don't really need to stretch anymore. You already got what you need. And so there's a grading scale called the Beighton score that looks at multiple joints and kind of looks at how extreme your arc of motion is at those different joints, and you can get a given score. I don't really know the scale, but people that can do things like this person in the picture where you touch your thumb to your forearm, we don't need to do joint mobs on that person's hand and wrist. There's no reason. They have plenty of motion already. We're only going to make it more unstable and potentially move those joint surfaces too far if we do joint mobs for somebody like that. The other ones are pretty much like any of our more intensive exercise techniques. If we've got a lot of swelling in the joint, we've got a lot of inflammation, we've got an active infection, we don't really want to move those things around yet. If you've got, let's say you sprain your ankle, you've torn a bunch of tissues, we don't need to go in there and start moving that foot around and potentially put extra stress where those little capillaries are starting to mend themselves. We're going to go disrupt them and kind of tear them back open and make them bleed more. So if they have an infection, and that's what this foot looks like, it's either got really bad gout or maybe a cellulitis infection, I'm not going to mobilize that. I don't want to spread that infection around or make that gout feel that much worse. It's not going to help anything. It's only going to make it worse. So if we got lots of mobility already, no need to do joint mobs. If we have any sort of active inflammatory condition, we don't really want to be doing joint mobs. So those are our big contraindications. Precautions. Well, if I saw a hand like this, that would put a contraindication in there. Unhealed fracture to me would be more of a contraindication. I didn't put this list together. I think it's from your book, but that would be more of one. I'm trying to think of a situation where you would want, where it would be okay to mobilize it, where it wouldn't just be a flat out contradiction. But if my wrist's like that, I'm not doing that. Cancers, we don't want to, that bone is likely to be fragile. And if we're doing a forceful joint mobilization, we might actually break it ourselves, or somebody that has really bad osteoporosis, same kind of thing. If it hurts too much, total joints, I used to do joint mobs on my total knee patients when I did home health. I didn't do them in acute care because that was very fresh. But when they came home and I was seeing them for home health 2 weeks after surgery and they were still lacking flexion or extension, I felt very comfortable doing joint mobs on them. When you look at something like a hip replacement or a shoulder replacement where the joints are inherently more unstable than a knee replacement, then I'd have bigger concerns about it, because you don't want to make those joints more likely to slip out of place. And artificial joints typically don't fit together quite as well as the real deal. But a knee, you got a lot of connective tissue around there. It's really only moving in one plane. It's a safer one to mobilize when it comes to artificial joints, but it does depend on how fresh it is. And if it's actively inflamed from, having just had surgery in the last 4 or 5 days, that's not the time to do it probably. Anybody that's got kind of weakened connective tissues, we don't want to go too far. Certainly somebody that has something like RA, their joints are already hyper mobile because you just basically have a lot of destruction of all the connective tissue. We definitely don't want to do joint mobs with people that have fragile muscles, tendons, ligaments, capsules, anything like that.
So Craig, with osteoporosis, is that going to be a precaution, or is it going to be?
It's a precaution, yeah. You'd have to think about where is it, how stuck are those joints, what kind of joint mobilizations are you going to use. We'll go into these different grades, and so you might be okay doing like a grade 1 or a grade 2 on, let's say you have somebody that has a really kyphotic spine and you want to do some joint mobs on their thoracic spine. I wouldn't do a grade 3 or a 4. That's more aggressive, but a grade 1 or 2, just to kind of help things move a little bit, might be okay. That's where it would be kind of that gray area, that precaution, as opposed to a flat out contraindication. Now, if they had compression fractures at that level in their vertebral spine, then I'm probably not going to do it where that compression fracture is. Yeah, Whitney?
Hey, Craig.
Uh-huh.
So when it comes to malignancies, is it specifically bone cancers that you are worried about? Or let's say like a woman comes in that has cervical cancer, but also had a total hip replacement, and you wouldn't really want to move basically that lower area?
If they know that the cancer has metastasized, then I'd be reluctant to do it, because bone is one of the most common places where Mets end up lodging. So if they have lung cancer that they know has metastasized, they have breast cancer that they know has metastasized, cervical cancer, if it's still felt like it's, stage 2, where it's still local in those tissues, and I wasn't mobilizing that area, then that would be more of a precaution kind of deal. But if I know for a fact that they've got bone mets, you don't know where all those bone mets are, so I would just not do it in that case. All right, so let's talk about these. Yeah.
So for people that have like RA or like osteoporosis, if if they like with fractures and stuff, like if you can't actually move stuff for them, what would be a good alternative to help them?
Just trying to do more gentle stretching probably than anything. See if they can work on their posture, do some, postural corrective strengthening exercises to help hold themselves in a better place dynamically, to see if they can overcome some of that. If somebody's got RA really bad in their hands, but it's not really affecting, their knee or their ankle, whatever, some other body part that you want to mobilize, then that's probably going to be more of our precaution thing. But if they've got it in their hands, then I'm not going to do finger joint mobs and wrist joint mobs and stuff like that. So that's, again, there's no hard and fast rule. Probably it's going to be pretty patient by patient, and where exactly are there problem areas that we need to treat, and where else has their disease kind of manifested itself. All right, so let's talk about these grades. There's two different ways that mobilizations are commonly graded. And so the Maitland one is probably the most well-known. These are oscillations. So you're going back and forth with them. And so if you look at the size of the arrows and how far we're moving, that kind of gives you an indication of how the grade is set up. Grade 1 and 4 move through a very small back and forth arc of motion. Where they differ is, are they right at the beginning of the available movement in that joint capsule, or are they right at the end where we're actually trying to push the limits of that joint capsule? But both of these are really rapid, almost like vibratory back and forth, so that if you're doing, actually let me hold this up because it's probably a little better. So if I'm doing this knee, let me get some slack on it. Can you guys see that? If I'm doing, so let's say I get them in what's called the loose pack position, which is probably somewhere about like this. If I'm doing a grade 1, I'm just wiggling it back and forth really rapidly, just trying to basically kind of, I'm holding my femur stable and trying to basically just shake the tibia kind of back and forth. If I'm doing a grade 2, I'm going through a bigger arc of motion, but I'm not trying to go as far as I can all the way till the tissue is taut in one direction until it's taut in the other direction. I'm kind of staying in that easy kind of mid-range portion, but it's a slower motion. One of our former program director, before she left, she would describe it as kind of like, if you're doing a grade 1 or a 4, it's kind of like the speed, like if you were doing a motorboat sound with a kid in the bathtub, going, making a little motorboat. You want it to be really, really fast, like a Theragun kind of fast. Obviously, we physically can't move that quickly typically, but it should be a very rapid oscillation. Grade 2 and 3 oscillatory modes, she liked describing it as more like the speed if you were shaking somebody's hand when you're first meeting them. So you're kind of going back and forth a couple cycles a second, but it's not this really rapid, like tremoring almost motion that we want to see with the grade 1 or the 4. So those are kind of the difference between the excursion. And so, like I say, grade 1 is going to mostly help with some of that proprioceptive feedback, helping maybe stimulate the nociceptors to not sense pain, help give that just the mechanoreceptor stimulus, move the synovial fluid around a little bit. That's kind of what's going on here. Grade 2, again, we're not going to the extremes of the available motion in that joint capsule on either end. We're staying right in the middle. Grade 3, we kind of start, we take up some of the slack in the joint, and then we're moving it through a big oscillation, but we are pushing into tissue resistance. So we're basically stretching the capsule a little briefly, because these are oscillatory at the end. And then a grade 4, we're basically staying really, we're kind of taking up all the slack of the joint. So if I was doing this knee, and let's say I was trying to come and help with gliding anteriorly, I'd pull it up to its edge, and then I would try and basically vibrate kind of when I'm at that limit with that one. If I was doing a grade 3, I'd go back just a little bit, and then I'd come up pretty firmly to the top. And this will make more sense when you start trying it in lab this week. So, yeah.
How long would you normally do like a joint mobilization? Would you do it for like a couple of minutes, 30 seconds?
Yeah, so usually it's hard to do it for a lot longer than a couple minutes. You'll kind of tend to get a little bit tired yourself, depending on which body segment you're doing. But yeah, a couple minutes is a pretty normal length of time that you might do. So these are 1, 2, 3, 4s. Grade 5 is another one, and that's a high velocity, low amplitude thrust. And so that's kind of what you do when you're actually trying to get a joint to pop. We take up all the slack in it, and then we do a quick, really forceful, high velocity, low oscillation movement to basically push the extremes. And that's when you think about somebody getting their back cracked at the chiropractor or having a PT do a specific joint mobilization on the spine. You're really moving it more extreme. And PTAs are not allowed to do grade 5s in any state that I'm aware of. There's dispute about what PTAs can do when it comes to this. And we normally have a debate activity in lab this week. I think for the lab that's going today, because we're still trying to catch up from what we missed last week, we probably won't do it. So I'm gonna go ahead and pull this document up, and let me see if I can make it a little bigger so everybody can maybe read it a little bit easier. And we'll talk about this briefly before we kind of keep going. So according to APTA, if you look down, this is basically defining what the PT can do versus what a PTA can do. And mobilizations come under one of the few procedures that are, according to APTA position statements, that PTAs shouldn't do. If we look down at the bottom here, such procedural interventions within the scope of PT practice that are performed exclusively by the PT include, but are not limited to, spinal and peripheral joint mobilization / manipulation, which are components of manual therapy, and sharp selective debridement, which is a component of wound management. So those are the things that APTA has traditionally recognized. Many state practice acts are written to reflect that policy. But there is differences, and we've had issues with chiropractic organizations trying to encroach on what PTAs can do by even saying, oh, well, if you're doing a stretch, then that's a joint mobilization. So they've tried to even say, well, PTAs shouldn't even be stretching patients. And we were like, wait a minute, that's not at all what we're talking about here. So it is kind of a gray area in practice. Now, what CAPD, which is the organization that accredits PT and PTA programs to, be able to let students sit for licensure, has a different take on it. And so if we look down at the bottom here, the commission believes it's not inappropriate to train PTAs to perform soft tissue mobilization or to manually assist the PT in the delivery of peripheral joint mobilization procedures, stabilizing or grade 1 to 2 movements. So according to CAPD, it says we can teach you guys how to do grade 1 and 2 mobilizations, where we're not actually stretching the joint capsule at all, like we do with the 3s, the 4s, or the 5s. So that's what it's talking about down here at the bottom, how we can teach you about how to do a grade 3 and a 4, but we're not supposed to pass off on it or anything like that, or really expect you to be competent in that skill. Again, different states allow for different things when it comes to this. And Utah's position, well, there's a whole article there. I thought we had Utah's act on here, but maybe not. Utah's position is basically that it doesn't really say really specifically. It does say that a PTA is allowed to teach a patient any mobilization technique that they can do themselves. So when we look at things like mobilization with movements, some of those are going to be with a grade 3 force. It's a different grading system that we'll go through in a second. But you guys can certainly teach patients how to do it. So we do include this instruction with this course, and then you'll hear it again in ortho a little bit more specifically. You should definitely be able to understand how to position a joint to do a joint mobilization, and be set up. And that's kind of the expectation for the practical, is that if you're going to do this joint mobilization to improve, let's say, flexion, how would you position the patient? What would you stabilize? Which way would be your movement force? And that's kind of the extent of what you would be expected to know on the practical exam for us. When you get out in the clinic, if the PT that you're working with is okay with you doing some of these treatments, then in Utah it's generally considered to be okay, for sure, with the exception of the grade 5s. And again, the grade 3s and 4s are kind of a little bit vague in Utah as well as many states. But APTA says no, PTA shouldn't do it. CAPTE says yes, you should teach them at least about the principles, and 1s and 2s are probably okay because we're not really pushing the limits of the joint capsule where we need to assess that really closely. So there's our Maitland scores, and those are, again, oscillatory. The other type of scoring that we have is Kaltenborn. That's another therapist that came up with this. I think it's a therapist, not a physician. And these are not oscillatory, they're sustained. So we're applying a gliding force in most cases and then holding it. And so this is really what we do with mobilizations with movement. And so grade 1 is pretty similar. We're just doing it kind of in the early part of the available space in the joint capsule. We're just moving it a little bit and holding it there. A grade 2 is basically we're separating the joint surfaces and putting stretch through the capsule just to the edge of its limit. And then a grade 3, we're actually applying and really trying to apply a good strong pull to it, so that we do cause more of a stretching effect. So those are kind of the differences between those scoring systems. The oscillatory have a 1 through 5 if you count the high velocity thrusts, 1 through 4 if you're talking about just a more traditional oscillatory motion. But then Kaltenborn is sustained. And like I said, when we get to mobilizations with movement, that's what Kaltenborn is kind of all about. That's what's used with those. All right, so a lot to think about. And these are things that we'll practice in lab this week. We need to think about that convex and concave rule. We're almost always going to stabilize the proximal segment and move the distal segment, because the distal segment tends to be smaller, lighter, easier to manage than the proximal segment. So you're almost always having to recognize, okay, what's the end of the distal bone look like? Is it convex or is it concave? And that will tell you which way you need to glide it to improve whichever motion you're after, whether you're trying to improve flexion or trying to improve extension. So if I look at my knee like this, and I've got my concave here, and I've got my convex here, if I was trying to improve flexion of this knee to make it bend better from an osteokinematic standpoint, which way do I need to glide it for my joint mobilization? Would I glide it anteriorly or would I glide it posteriorly?
Anterior?
What'd you say?
Anteriorly.
So if I did anteriorly, remember this is our concave bone. So we want the glide to be in the same direction as the osteokinematic motion. So if I'm trying to flex, then I want to glide it posteriorly in that case. If I'm trying to improve extension, where the tibia is going to move anteriorly, then I would want to glide it anteriorly, and that would help it. If I go down to the foot, now I've got a different scenario. At the foot, the talus is convex, and the underside of the tibia is concave. So now if I'm trying to improve dorsiflexion or plantar flexion, that's going to flip. Because now if I'm moving the foot relative to the tibia, now I need to go the opposite direction. So if I'm trying to help improve dorsiflexion, where the foot is moving anteriorly, my glide needs to be posterior. If I'm trying to improve plantar flexion, where that where the roll is going to bring that talus posteriorly, then I need to glide it anteriorly. So it switches based on which is convex and which is concave. And if we're moving the concave bone, then we glide it the direction that we think the whole bone is going to go to improve that motion, whether that motion is flexion, abduction, internal rotation, whatever the case might be.
So, Craig, when you're gliding, are you putting any distraction on it?
Yes, you're going to distract a little bit and then glide with it, because we do want to separate those joint surfaces so that we're not just grinding them. We want to separate them and then try and oscillate with those. So yeah. All right, so if we're going to do this on a patient, we need to understand which direction we're going. We need that patient to be really relaxed. If they're guarding it all, holding their muscles tight, we're not going to be able to move those bony ends, and we're not going to be able to accomplish the treatment. So this is where doing things like heat can be very helpful in helping the person relax. Even an active warm-up, cycling or something like that to get the blood flowing and loosen things up just a little bit might also be a helpful treatment besides just something passive like heat. But we do need to let the person be relaxed. We want the patient to know what it feels like if we're trying to do a grade 1, a grade 2, a grade 3, a grade 4. And we want to look at their motion. Before we did it, how far can you lift your arm? Okay, let's mobilize that shoulder. And now how far can you lift the arm? Oh, look, you can go 10 degrees further. It worked. So we want to be able to assess whether what we're doing is actually accomplishing what we think it is or what we should. And it shouldn't really be painful. They should be fairly pain-free. Certainly the grades 1s and 2s should be pain-free. The grade 3 and 4, where you're actually pushing tissue limit, might be a little uncomfortable, but it shouldn't be painful. If it's painful, then we need to back off. We need to think about good body mechanics for them, but also for us. So if you need to stand on stools, if you need to, position the patient a certain way to help you get in a good position, you have to kind of think about all of those things. Gravity can be our friend, especially if we're trying to mobilize a heavy bone like the femur and trying to control the whole thigh. You definitely want to think about which way gravity is going to help so that you're not having to fight it so much and wear yourself out. And then we typically start out easy. So even if our goal is to try and get to a grade 4 mobilization, we're going to start out just moving it gently and kind of get a feel for it and then build into some of the more higher grades if that is needed for that particular patient. Positioning, again, we need that patient to be able to relax. So a lot of times we are going to have the patient be supine or in a very well supported position. And then we have to stabilize the proximal segment typically so that we can then distract and mobilize the distal segment. And so you can see this person doing a wrist here. They've got the forearm supported on the plinth. Even with that, they're all bracing and stabilizing the radius and ulna, holding the hand basically. So now I can move just the wrist joint for my mobilization. Over here, he's getting his shoulder worked on, and you can see this strapping apparatus. You can actually strap the person down to the table so they're nice and stable, and that way you can use 2 hands to move the segment that you're after, and that makes it easier to control. So that's what all this is just kind of a set of straps to kind of anchor the person to the table to make that more helpful. We want to make sure that our force is only going the direction that we want it to go. And we want to also keep our hands really close to the joint surface that we're trying to move. So if I'm doing the tibia, I want my hand to be right here. I don't want to be 3 or 4 inches down the shaft, because then I'm starting to get the whole bone moving back and forth, and I want it to be just the bony surface. So I want to stabilize really close to the joint surface that I'm trying to move, but especially the hand that's actually moving the bone that we're interested in needs to be really close to that joint surface as we're doing that motion. Otherwise, we're going to start making the bone torque a little bit more and not feel great and not accomplish what we're after. Large contact surface is going to help. So I had my hand kind of like a U when I was wrapping that tibia, as opposed to trying to just do it with like my fingertips or something like that. Broader hand surface, you're going to have better control and you're going to be able to kind of control more of the different motions, especially when we get to a joint like the shoulder that can go lots of different ways. The more we can really control that proximal end of the moving bone, the more effective and more appropriate our treatment's going to be. We typically are going to need to have our treatment force usually be parallel to the treatment plane. So if I'm looking at my tibia, the treatment plane is where the tibial plateau is. And so I'm directing my force straight back or straight forward, so it's parallel with that. In the case of like the shoulder, you might have times when it's perpendicular because of just the configuration of the shoulder joint. So if I go up just a touch on that, so the face is right here, and I might need to move it this way, or I might need to move it back and forth that way. I can't be parallel in all those different directions. Some of them are going to need to be more perpendicular to that surface when we look at those joints that have multiple planes of action. But you're typically trying to get a little bit of distraction and then trying to slide or glide one direction or the other. All right, almost time for a break, I promise. So here's how we would kind of incorporate doing mobilizations into a treatment session. We would warm up the tissues, again, whether that's with heat, whether that's with an ultrasound, whether that's with active work, riding a bike, walking on the treadmill, doing an upper body ergometer, or whatever the case would be, something kind of low level just to get the blood flowing and get the joint moving a little bit. We want to get the muscles nice and relaxed. So if they are guarding a whole lot, then we need to try and help them reduce that tone a little bit, possibly using some of the PNF techniques that we talked about. I know one lab group went over that last week. The other ones will work that in today for you. Then we're going to get into the actual joint mobilization session. Again, a few minutes here and there. You might do multiple reps of a couple minutes, kind of see how the patient's doing. If it's continuing to help, then do another couple minutes and see if it continues to get better. Then we're going to kind of stretch the whole area. So let's say I was trying to work on improving shoulder flexion and I did my mobilization that should in theory help with that. Then I might have the person actually try to do some stretches up in there, whether it's passive or active assistive or active. And then we're going to have them use it. So they're going to perform exercise, whether it's range of motion, resistance, stretching, whatever the case might be, in that new available range, and then ideally put it right into use. So have them, let's say I worked on doing my shoulder flexion and I did my exercises and it's doing pretty good. Now I'm going to say, okay, I want you to take this stack of cones and pick up one from this low surface and then restack them all up at this high surface. So now you're functionally having to retrain the body that, look, your shoulder can move this far now. It's not killing you to lift your arm up that way. There's no reason for you to do this to get your arm up. You can just stay straight and lift it up. So we're trying to just reinforce those correct movement patterns once we've freed things up and gotten the joint moving a little bit better. Does that make sense on that sequence? All right, so mobilizations with movement. I do not claim expertise really with any of the joint mobilization stuff, and I'll probably have Johnny teach a lot of this because he's better at it and he's been doing it longer than I have. The guy that used to teach this was OCS certified, and so he had to really beef this area up a lot to try and help people feel more comfortable with it in ortho, I think. But it's definitely not something that I did a whole lot. So I'll throw that out there right now. But mobilizations with movement are were theorized by this person named Mulligan. And the idea is we're going to do a pain-free accessory movement while the patient is doing the active physiological movement. And so that's what's pictured down here. So the therapist is stabilizing the talus by basically kind of coming around in front of the foot and kind of bracing it so it's not going to move. We've got this towel around the back so this strap doesn't dig into the back of the person's leg. The person is actively trying to go into more dorsiflexion while we block that talus from moving. And then when they get to their end range, then we have this belt going around our hips and we're leaning our weight back to try and then help glide that tibia just even more anteriorly relative to that talus. Now this switches the dynamic, because in this case, we are stabilizing the distal segment because the foot's not moving and we're anchoring that talus. And now we're trying to help move the proximal segment. So that's a little different than what I showed you if I was just going to mobilize the foot, where I would stabilize the tibia. So now my convex and concave rule, I have to think about which thing I'm moving. So if I'm trying to improve dorsiflexion and I'm anchoring the distal segment, the foot's on the ground or on the table, and I'm stabilizing that talus, now it's the concave tibia that's moving forward on the stationary talus. And so I need to help glide it in the same direction that the tibia is moving, because it's this concave segment. So I'm going in the same direction with that. You can also do this mobilization with a strap. And sometimes people do it with like the long, they're like, I don't know, 4 feet long, 3 feet long elastic bands. Hook one end underneath a stationary object, put the other band across the dorsum of your foot so it stabilizes the talus, and then you can just move forward. We're gliding the talus backwards while we move into dorsiflexion. So you can kind of flip it around a little bit depending on how you're doing it. And so it is important that this be pain-free. We're only going as far as the patient goes while still being pain-free. And then we're just going to do 5 to 10 reps, and then have the person try to do the motion without that external force. So now you can have them do some exercises where they're going into more dorsiflexion, and then potentially add in a functional exercise that makes them go into dorsiflexion, like squatting down or something like that. This last part on the comparable sign, we're trying to get a sense of what was their uncomfortable sign. When you did dorsiflexion and you couldn't go as far as you needed to go, what stopped you? Where were you having pain? What did it feel like? And so then we do this mobilization with movement treatment, and then we ask them again, how does that pain that you were having feel now when you do that motion? Can you go further before you feel it, or are you still feeling it where you felt it before? If I felt it when I went into 15 degrees beyond neutral, and I did the treatment and I still felt it there, when the treatment didn't really work. But if I did that treatment and now you can go 25 degrees past neutral before you feel it, well, now I've made improvement in that comparable sign. It's still there, but I can go further before I feel it. Or maybe it's not there at all. Because you've kind of helped the joint figure out how to move a little bit more effectively. And this is a dynamic thing. It's not passive like it is with us doing a peripheral joint mob on a patient. And so sometimes the thought on these sometimes is that maybe you're just tricking the brain into recognizing that I can do that movement and it doesn't hurt. There's a lot of research going on lately about chronic pain, in particular when people have these chronic injuries, that they just interpret any movement of that body part as pain, even though there's no really actively injured tissues. But your brain gets so used to it hurting when you do that motion that we have to kind of trick it and kind of show it, look, you can do this motion and it actually doesn't hurt. And then people will start going, oh yeah, I can do that. It's kind of theoretical, but it seems to be applicable with things like this.
Hey, Craig.
Yep.
Can you explain a little bit what overpressure means? I saw that a lot in the book and I couldn't really find an exact definition. Is it exactly what it says, or is it something specific?
Yeah, so I mean, overpressure, like in that example that they were showing there, let's say I have the person coming into dorsiflexion as far as they can. Overpressure would be just me using that strap from behind to then pull forward more. And again, we've got to keep that strap pretty low so that as we pull it forward, it's just pulling the tibia at the joint forward, and we're not like pulling the knee forward too. We're just trying to make it glide. And so that's where the overpressure is for. It's just trying to help overpressure into the accessory motion that we're after with that. So it's really taking up the slack in the tissue and then stretching it a little bit beyond that. It's kind of the overpressure part. So I would recommend bringing this book to lab for Ther Ex this week. It has all the pictures of how you set people up to do all the different peripheral joint mobilizations. And then it also goes through some of the mobilizations with movement that we'll do. So I would say not everybody needs to have it, but like if each pair of lab partners has a book between them, then you're probably fine. But this would be the most helpful book for this week for Ther Ex to have, just because it does have all the positions shown pretty clearly for all those body parts. All right. I think we'll take a break, and then we'll come back and we'll talk about the soft tissue injury stuff. So it's 9:16 on my watch. So take about 10 minutes, and I'll see everybody at 9:26, and we'll talk about soft tissue injury. So when you got tired of the blonde?
I'm trying to make it healthier. So this is my natural technically.
Okay.
Yeah. So I got tired. I just knew it was dying. So I was trying to do a good deed for myself.
You put it out of misery since it was already dying.
Yes. I'm still adjusting because I forgot how dark it really was. This is,
Yeah. My hair when I was a kid was like bleach blonde. And then I did swim team every summer. And so then I'd get that nice greenish kind of tint from too much chlorine in the pool. Then as I got older, my hair just got darker and darker and then started going away entirely.
Yeah, I was a blonde haired, blue eyed, curly child. I was like a Shirley Temple, basically. It was really bad.
Little ringlets?
Yes, yes. Oh my goodness. That's how, like, I think that's how I was distinguished as a baby, was the curly cues.
So when my parents got divorced when I was like, I don't know, 12, and at some point, like within a couple of years after my parents got divorced, my dad had like his midlife crisis. He bought a sports car and then he got a perm, and he had these little ringlets. And his hair is like mine. It's pretty thin, and it didn't look good. And whenever we pull those pictures out somewhere, he definitely gets a lot of grief from his perm.
Oh no.
So, yeah.
Oh goodness. Now don't you follow the footsteps there.
Yeah, I learned from that mistake and said, yeah, I'm not doing a perm no matter how much I want one, which is fine. Don't, but I didn't.
Really a thing now though. Only just getting the top part, I guess.
Yeah.
Hey, Craig.
Uh-huh.
So I worked at a outpatient orthopedic clinic that had McKenzie certified PTs, and they used a technique a lot with the knees where they would take a TheraBand and either have the TheraBand placed above or below the knee joint and apply either, abduction or adduction forces.
Yep.
Would that be an example of like mobilization with movement if they then have the patient go into flexion and extension?
Yeah, and with the knee, with the mobilizations with movement, we kind of throw out the convex and concave rule to a degree, and it's more just whatever accessory force we're providing needs to make them more pain-free.
Okay.
For whatever reason with the knee, it seems like the lateral glide seems to be the most helpful. And so, yeah, you basically have that elastic band pulling their knee out to the side while they're doing, sagittal plane motions, and it helps it track a little bit better and helps improve their movement is kind of the theory on that. With, the example that they showed in the picture with the tibia and the strap behind it, that's, in the same plane, and that one is following the convex and concave rule. But with the hip and the knee in particular, a lot of times we're using just more of a lateral glide as we have the patient do that with the mobs with movement. So yeah, and when you use that elastic band, then the patient can theoretically do it themselves at home. If they find that it's really helpful, then they can just get one of those themselves and figure out some place to anchor it at home and take it over.
Right. They use that a lot with like a suspected meniscus issues.
Yep. All right. So let's talk about soft tissue injury. And I know you guys have gone through the stages of injury when we look at the inflammatory and the proliferative and the maturation or remodeling stage, both in pathology. And I think you've already talked about it in modalities too, I think, in the beginning of that class. And so this kind of just builds on that. And we'll look at acute, subacute, and chronic. And then we'll talk about chronic inflammation too. And kind of just look at general recommendations for when it's most appropriate to move from passive to active assistive to active, when it's most appropriate to move from isometric contractions to concentric contractions to eccentric contractions, things like that as we go through these. So we've got our different types of soft tissue lesions. And so strain and sprain, hopefully you know the difference on those. Strain is going to involve muscle or tendon. Sprain is going to be ligament, joint capsule, potentially. Dislocation, you're likely to have more of a sprain go along with a dislocation. Certainly you could dislocate far enough that you damage muscle tissue, but usually when we're looking at a dislocation, it's going to be the supporting ligaments that are overstretched the most to allow that joint to move out of place. And that's kind of what you're seeing down at the bottom picture here. This would be a dislocated shoulder. You can see the acromion right there on that right side. And then the deltoid is kind of significantly depressed, whereas on the other shoulder that's intact, we have this nice line coming down where the upper trap is, and then this goes right into that rounded contour of the delt. And so the head of his humerus is essentially kind of shifted down anteriorly, and that's the most common place for a shoulder to dislocate. So the head of his humerus is probably kind of right in here, and it needs to be back over there. Up top, this would be a muscle tear. So this is a bicep tear, and I'm guessing it's probably the long head of biceps brachii has torn on this gentleman. It's still anchored down here, and then the short head is still anchored, but you get this big ball look. It looks like he's got a tennis ball kind of right in there because that upper head broke, and it's just kind of like it just retracts. I don't know if you ever watch cartoons. They'd like pull some guy's tongue all the way out, and they would like roll back up. I don't know what cartoon did that, but I know that seems like Wile E. Coyote or somebody had that done to him probably before the anvil fell on his head. But that's kind of what happens with that, is it retracts like that. And they have to surgically fix it pretty quick or things will get way too short. This guy's got a pretty impressive pec, by the way. Not really. It's kind of saggy and hairy. So other soft tissue lesions, we've got tendinopathies, and so that's going to call into play tendinitis, which is more of our acute inflamed tendon term, our tendinosis, which is more of our chronically kind of degenerated tendon, and then tenosynovitis. Some of our tendons, especially like our finger flexor tendons, have a tendinous sheath, and the tendon slides within that sheath. If you think about like brake cables on a bike, you've got that outer plastic coat housing, and then the cable that glides back and forth within it. That's kind of how some of our tendons are set up. And a tenosynovitis is just an inflammation of that sheath, so that every time that tendon moves, it's very irritating for that person. Synovitis would be any synovial joint, basically just the synovium itself is inflamed and irritated. And we see that a lot with RA, but it can also happen with other joints too. And then our last major classification is going to be our overuse syndromes. And usually those end up being some kind of itis, whether it's a tendonitis or a bursitis or an arthritis. So that can be most anything that just wears down that tissue, causes it to lay down more scar tissue and become kind of less functional over time. So those are kind of the things that we're talking about having to treat, all those different lesions. So we'll see this slide on the right for us, the next handful of slides, and it's kind of showing you when the person experiences pain. If we look at these two kind of vertical lines on this bar on this A1, these are trying to describe kind of the normal available range of motion before we feel any kind of stretch. And so if you're in the acute phase, you don't even have to get to the end of its normal motion before you have pain. Let's say I have pain in my shoulder, and normally I should be able to go that far. If I'm the acute phase of injury, I'm going to lift it up to here, and that's already painful. The first little bit of motion I'm okay with, but as soon as I start putting any kind of tension whatsoever through that area, I start having pain. So that's kind of where we are with acute. And things are very inflamed. We really need to be resting it and calming down the inflammation more than anything. Movement's not really our friend that much at this point. If we are doing things, it's very gentle, very limited arcs of motion. If we're doing any kind of strengthening at all, we might be doing some very light isometrics, but it's mostly just kind of babying it and letting things calm down at this stage. Our B is kind of our subacute phase. And so with subacute, I can go through that full arc of motion, but when I get right up towards the top, I'm like, okay, now I'm starting to feel it. And so that's where you see this little pain, this jagged symbol up here that's representing pain is kind of right at the limits. If I take it through its normal range, that's when I start feeling pain, is right at end range. After things have healed a little bit more and we get into kind of later in our subacute phase, Now I can actually put a little bit more stretch through that tissue, and now it's painful at the top if I really try and kind of push its limits. So that's kind of where we are here. And then when we get to true chronic, then hopefully we can kind of complete that whole arc of motion, and we keep pushing that pain out of the picture, essentially. So that's kind of, like I say, what this graph is meant to show. And so acute, again, mostly our goals are just calm things down, try to not let it stay totally inactive, but we have to be more about guarding the tissues and letting them start to mend themselves, stop any immediate bleeding effects from torn tissues, things like that, clean up some of the cellular debris. That's kind of our goal at this stage. So a lot of pain control, very gentle motion, gentle isometrics, gentle partial range, passive range of motion are kind of our treatment things that we're doing right now. Once we get past that acute phase, which different injuries have different timelines, but let's say 72 hours, that's a fairly common one to look at for a lot of injuries as being that early acute phase. We get into subacute. Now we've got inflammation's calmed down. We have pain only when we put a little bit of stretch through that tissue, when we get to the end of that normal range. And so we want to start trying to help move things a little bit better. So we're actually going to do a little bit of mobilization of the scar. So we might be introducing a little bit of gentle joint mobilization, for example, at this stage, or some gentle friction massage, things like that, to try and keep any adhesions from adhering, and start trying to teach the muscle how to fire again. So we're going to get a little bit more aggressive with our strengthening exercises in the subacute phase. We want them to work on going from just doing passive range to active assistive range to potentially active range at this phase. As far as strength is concerned, instead of just doing gentle isometrics in kind of a relaxed position, we're going to move into doing our multi-angle isometrics. So if I have, let's say I'm strengthening up a quad, I'd want to do some quad strengthening, say at 90 degrees of bend, again at like 70 degrees of bend, again at like 50 degrees of bend, 30 degrees of bend, and then more or less straight. And the theory behind that is research has shown that if you do isometrics, you actually get some strength kind of plus or minus 10 degrees or whatever position you were in. And so if I do strengthening every 20 degrees or so, then I should kind of help improve strength throughout that whole arc of motion without actually making them do a concentric, eccentric kind of load to go through that full arc of motion. So I can be more controlled. Isometrics are a more gentle type of exercise than either concentric or eccentric. So we're still kind of treating that tissue in a fairly babying, gentle kind of way, but we're making it want to start regaining a little bit of strength. We can work on doing some stabilization exercises, and most stabilization exercises are really pretty similar to isometrics. Any kind of weight-bearing activity is going to help perform some stabilization. And then we can have the person do reaching activities off the base of support. If they're, let's say they hurt a shoulder, then we can have them in quadruped with both hands on the ground and have them reaching with the other hand so that the affected side is now having to weight bear and kind of stabilize while I do just little subtle weight shifts and things. And that will, again, help the muscle that's injured gain some strength, but not really making it work at any kind of extreme ranges of motion. That midpoint for that muscle is usually going to be the most pain-free area. It's when we elongate it too much in one direction or the other direction that the person usually is going to have more pain. When we look at that, those slides that have the little pain thing moving in, if you don't have stretch on the tissue, then it's generally more comfortable. And then we can start trying to work on doing some functional movements. Again, and that might be something light like stacking cups or things like that, moving it from a low to a high so that we're functionally having to use that motion that we've just improved a little bit, but it should be very light. We're not really trying to challenge the muscle at all at this phase because the tissue is still kind of on the delicate side of things. Once we get to our chronic phase where we really we can put a little bit of stretch through the tissue before the person actually has pain. So that's the pain after tissue resistance. Then we can get more aggressive with trying to break up any kind of adhesions, trying to move into more larger arcs of motion, more of our concentrics and our eccentric motions than just isometrics and stabilizations. And we're less likely to injure the patient as we start progressing those. Again, there's a huge continuum of things that we can do from, just let's say 5-pound cuff weight on the person's knee, doing knee extensions with that versus plyometric jumps would all kind of fall into this range. So from pretty low level concentric eccentric motions to really dynamic, ballistic, high impact activities would be like as they're moving out of chronic management and back to kind of return to play level of stuff. So this chronic stage includes the broadest range. And when somebody's just transitioning from subacute to chronic, then we're more on those easier strengthening moves. And then as they get further along and have continued to heal, then we can move into some of the more dynamic, aggressive things, jumps and hops and explosive movements and higher loads and things like that. Now, chronic inflammation, a little different deal. Chronic inflammation is going to be more of like our tendinosis type of situations where the person's had pain in that area for months, potentially years. Some of it could be up here where they just have that anytime I move that body part, it hurts kind of mentality. And so it's kind of a self-fulfilling prophecy that yes, your body's like, anytime I move it, I feel pain. And the pain science research says your body is probably just being tricked into thinking any signal it's receiving is a pain signal, when it could just be some other mechanoreceptor signal of tissue stretch that you're feeling. But the body interprets it as pain. Chronic inflammation is hard to get over. And I had chronic inflammation in my heel before I had surgery for years, and I'd aggravate it and I could get it calmed down. I'd aggravate it and I'd get it calmed down. And what more and more research lately is telling us is that really when you get to that phase, you kind of stop the inflammatory process. You're not really releasing the growth hormones that actually drive inflammation. It's just that the tissue quality is starting to degrade from being just constantly irritated. And so many people think we need to basically start over again and just re-irritate that tissue so that it now becomes actively inflamed again. And if we can get it actively inflamed again, then we can kind of start from scratch and do it the right way this time. If you think about like a house that's maybe suffered water damage and your sheetrock has kind of gotten mushy and messed up, you can try and patch it and it might look a little bit better for a little while, but if we haven't fixed it from the get-go correctly, you're never going to get it perfect looking again. And so that's kind of the idea. We need to rip out all the old sheetrock, rip out all the old kind of bad tissue repair that happened with that chronic inflammatory process, and now try and help the body recognize how it needs to heal itself in a better way so that the tissue now becomes functional again without becoming inflamed every time we try and put forces through it. Yep.
So is it more likely an actual like structural issue rather than like CNS sensitivity? If you can, let's say with me, like I can run initially and be just fine, and then, pain starts to happen. Do you think that versus like having pain initially when you start running?
It can be, a lot of times with chronic inflammation, it's kind of the opposite. It'll be bad at first. When you first get going, it'll be really painful. And then once you warm up the tissue, then it moves a little bit better. And then once you quit, it kind of gets stiff and tight again. That's kind of the more typical chronic tendinopathy type pain. When you haven't moved it in a while, it hurts to start moving it. But once we get the blood flow, then it loosens up a little bit and feels a little bit better. But then once we quit and sit down, it stiffens back up again. That's kind of the more classic kind of chronic pain profile when we try and engage in activity. Now, certainly if you go long durations, then it may act up before the end, before you quit. But a lot of times once we kind of get the tissue warm, it's okay, as long as we're not pushing the extreme ends of range of motion with it. We're keeping it in a more functional, limited arc of motion, then it can be relatively pain-free.
Okay.
So the techniques that are listed here on this kind of indented bullet points, A-stim and Graston, those are both kind of aggressive scraping type techniques where we use an implement to try and target scar tissue and adherences in the scar tissue to kind of break it apart. And again, that would introduce some new trauma to the tissues that would theoretically jumpstart the inflammatory process over, move out from being chronically inflamed to get it back to being acutely inflamed, so we can get the proper release of healing growth factors and hormonal responses and things like that that might help us actually create new, more functional tissue in that area.
I've had that process done and I got great results.
Yeah, and it works great for some people. Some people it's kind of like, yeah, it didn't really help. I think it depends on the body part. It's not the most comfortable technique, especially if you're going over near tendinous insertions where you're like kind of that bone tendon interface. Can be pretty painful. If you're doing it more in a muscle belly, that's a little bit more tolerable. It can leave pretty significant bruising for some people. Other people tolerate it pretty well without a lot of bruising, but it can be uncomfortable for sure. I had it done on my Achilles, and it was really intense. I had one particular spot where I think one of my internal sutures was that when our former faculty member Robbie was doing it on me, it was exquisitely painful. That's a nice word. That's a big fancy word, but exquisitely painful is just really, really sharp, very distinctly painful. So it was not a comfortable feeling, but it did help. Friction massage is kind of more the manual version of A-stim or Graston. And you guys will learn about massage, I think, pretty soon in modalities. I can't remember where that falls in that course. But that's kind of the same idea. We're just trying to do some back and forth, circular back and forth friction type movements to kind of break apart some scar tissue, similar to the theory of Graston or A-stim. And then eccentric overload is one of the key strengthening exercises that we feel like can really help somebody with chronic inflammation get over it and help improve the strength and the tensile quality of the tissue that we're working. So I did lots of heel drops for my Achilles. Basically, I'd help myself up onto 2 feet, take 1 foot off the ground, and then slowly lower back down to eccentrically load my Achilles. And just doing lots and lots of those is believed to also, again, your eccentric contractions are the most stressful kind on the tissue because we're telling it to contract, but we're also lengthening at the same time. So we're kind of pulling it towards the middle to cause contraction and control of that segment, but we're also moving the bony ends apart on that. So we're both stretching and engaging that muscle at the same time. And that's where we get more muscle tissue damage. But again, if we're trying to help somebody get over chronic inflammation, we need to get it acutely inflamed again. And those eccentrics kind of overload that muscle in such a way that it's going to be a form of exercise that kind of supplements these more hands-on techniques of Graston and friction massage to try and help with that. And in particular, I think with tendinopathy problems, the eccentric overloads are pretty commonly thought of as being, if not the best single strengthening exercise, certainly one of the best. And so depending on where somebody has a tendinitis, then you'd have to figure out, or a tendinopathy, I should say, how to eccentrically load that muscle to help improve it in that way. All right, I think we're probably about done. Looking at my clock there. The case studies that are on these last few slides are really the ones that we looked at when we looked at range of motion. Not the last range of motion activity, but the first one that we did, where you had to kind of look at the case and decide, when would this be better for passive? Would this be better for no range? Would this be better for active assistive? And that's what these cases are. I thought they were different, but when I looked at them this morning, I was kind of like, no, they're pretty much the same. And so we applied the range of motion types to those case studies, but we could certainly also look at case studies like that and decide strength-wise, what would they be ready for? Stretching-wise, what would they be potentially ready for? If we're doing mobilizations, would they be appropriate for doing joint mobilization? So we can kind of think through those things as well. And that's kind of, as you move forward in the program and get into different, the more advanced classes next semester, like ortho in particular, you've got to figure out, are they acute? Are they subacute? Are they chronic? Are they chronic inflammation? And once we figured out what stage they're in, then we kind of have a better idea of what do we need to do to help them keep moving beyond that stage, to go from acute to subacute, to go from subacute to chronic, to go from chronic, recent chronic, and keep them from developing long-term chronic inflammation. So that's kind of the key on all of those questions that you're asking there. You should be able to think through these different injury types. Did they just have surgery? Were they just in a car wreck? Were they just have lots of potential muscle damage from whiplash or something like that? Were they, did they have a really bad ankle sprain? Did they have, ACL reconstruction? Did they have, finger tendon repair? And then that's really going to guide our choices. And you'll be working closely with whichever PTs you're working with to help figure out when these patients are ready to progress from one kind of level of activity to the next. And it is a continuum. In many cases, we're going from passive range to active assistive, and maybe they're good active assistive for certain motions, but some other motions, they still might need to be passive. Different things will progress at different rates. And we just kind of have to use our knowledge and experience to get a sense of when patients are ready to progress. And that is a tricky thing. And we always want to err on the side of being too gentle as opposed to too aggressive, because if we're too aggressive and we damage things too much, then we've set that patient back. If we're not aggressive enough, then we've potentially slowed how quickly they could get back to work or play or their sport or whatever. But that's a better alternative than re-tearing something and putting them a month back from where they had made progress previously. So those are those cases. I don't think I'll go through those since we already looked at them from the passive range and we're about out of time. So any last minute questions?
So with what you're saying, it kind of made me think of like with shoulder surgeries, rotator cuff repairs, that external rotation is often one of the most painful and the last motion to come.
Mm-hmm.
As you're designing and deciding what stretches and exercises they may be able to do, more, let's say, in the sagittal plane than in the transverse plane. So you could progress those sagittal exercises while you're still kind of more basic and then like that.
Yeah, you could be doing, whatever TheraBand exercises potentially here, but you might still just be doing isometrics for external rotation and then multi-angle isometrics. And maybe you're already on to doing eccentrics with flexion and extension. So yeah, different motions could have different amounts of pain depending on what got repaired or what got sprained or what got torn, strained, whatever the case might be.
So it's okay to progress exercises in certain planes before others.
Yeah,
Okay.
I mean, certainly sometimes with orthopedic stuff, you might have surgical precautions why they don't want this given motion, but in many cases, it's going to be what's still painful and what's not painful. And if it's not painful, then let's keep working that area ahead, and then we'll be kind of dealing with other things for the painful part. See if we can keep doing things that reduce that pain, and then start easing into the more gentle movements and the gentle strengthening exercises for those particular motions that are more tender, more painful.
Okay, that makes sense.
Okay. So yeah, bring your book for lab today. For those that have lab today, we'll probably jump into the stretching that we didn't get to last week, since you guys didn't have Monday lab. And then we'll spend the rest of lab. I'll talk to Johnny about how we want to divvy it up and split it, but we're going to try and get you through what we covered with the Tuesday, Thursday group last week, which is just the stretching component. And then also try and work in all these joint mobilizations and the mobilizations with movement. So I'll get with Johnny when I go in, and we'll kind of figure out how to divvy things up and go from there. All right. Very good. We'll see about half of you folks in about an hour.